Good afternoon to all the delegates who are here. So the anesthesia technique for cataract surgery has evolved over time to reduce the risk and complications, making the anesthetic procedure safe and efficient. Regional or local neural blockade is a preferred technique for surgery, which involves blocking the nerve by infiltration of the area around the nerve with the local anesthetic agent. The choice of regional anesthesia for cataract surgery varies from retrobulbar, peribulbar, subtenon, subconjunctival, topical, or a combination of any of these blocks. So retrobulbar anesthesia, which was previously used, was replaced by peribulbar due to the complications like laterobulbar hemorrhage, globe perforation. But still, there might be needle-related complications with peribulbar as well. So subtenon's anesthesia technique has emerged as a safer and effective method without these needle-related complications. So this study aims to compare effectiveness of subtenons with peribulbar in a manual small incision cataract surgery in terms of akinesia and complications. This is a prospective comparative study conducted at Akash Institute, Devanalli. A total number of 60 patients were selected for the studies. The study was conducted after taking the informed consent, and the patients were divided alternatively into peribulbar and subtenons group. The pre-operative evaluation included visual acuity, a detailed anterior segment under slit lamp and fundus examination as well. Intraocular pressure, sac syringing, routine examinations like RBS, blood pressure, serology, everything was done. 30 ml vial of 2% lidocaine with adrenaline, 1:2 lakh, mixed with Hylase 1500 international units was used as anesthetic agent. So for peribulbar group, the eye was painted with 10% povidone iodine, and the 3 ml of anesthetic mixture was injected using 23 gauge needle at the junction of outer 1/3 and the inner 2/3 of the lower orbital margin, with the needle directed towards the floor of the orbit. An additional 2 ml injection was given at the supraorbital notch. Eyelids were then closed and intermittent pressure was applied. For the subtenons group, the site was painted and draped with aseptic conditions. Slit speculum was placed after installing the paraffin drops. Under microscopic visualization, nick was made in the conjunctiva using a Westcott scissors inferonasally 4 mm from the limbus. Subtenons cannula was then inserted to the bare sclera and guided along the contour of the globe till the hub of the needle touches the sclera. Using a 5 ml syringe, 3 ml anesthetic mixture, the drug was injected into the subtenon space. The time of onset of akinesia was noted and the graded based on restriction of the movements during the surgery. The complete restriction of movements in all quadrant is told as grade 1. Eye movements less than 15 degree in any direction of gaze is grade 2. Eye movements more than 15 degree as grade 3. The results were the total 60 uncomplicated senile cataract patients underwent manual cataract surgery with 30 patients in each group. All the surgeries were done by two senior surgeons. Most of the patients, around 78.33%, were between 60 to 70 years of age. 35 patients were male and 25 were female. The time of onset of akinesia in both the groups showed a significant difference, with the mean time of 6 plus or minus 2 minutes with peribulbar and 2.5 plus or minus 1 minute with subtenons group. However, the proportion of patients with complete akinesia was significantly greater in peribulbar group, with 76% than in subtenons group, where 70% of the patient were having less than 15 degree eye movements. The chemosis and subconjunctival hemorrhage was more in subtenons anesthesia when compared to peribulbar. These were the results. Complication as chemosis, which was 37% present in peribulbar and 53% in subtenons. And subconjunctival hemorrhage, it was 13% in peribulbar and 43% in subtenons. And akinesia, peribulbar showed the full akinesia constituting to 77%, and subtenons had less than 15 degree, around 70%. In our study, onset of akinesia was faster with the subtenons block compared to peribulbar. This was also supported by Ashok et al. And only 5 patients in subtenon group had total akinesia, and 21 patients had less than 15 degree in peribulbar group. The amount of anesthetic mixture used for peribulbar anesthesia was 5 ml for subtenons, and for subtenons it's 3 ml. Although the akinesia grade was lower in subtenons group, it was acceptable by the surgeon during the surgery. In this study, 53% of the patients in subtenons group had chemosis compared to 37% in the peribulbar group. However, chemosis did not interfere with the surgery, whereas Park et al. Did not find any significant difference in the occurrence of chemosis between the subtenons and the other peribulbar group. The occurrence of subconjunctival hemorrhage was significantly high in subtenons compared to peribulbar. Subconjunctival hemorrhage may be due to damage of subconjunctival vessels or during dissection of their subtenon space, and chemosis was probably due to injecting getting deposited in the wrong anatomical plane. Conclusion is subtenons and peribulbar are both effective anesthesia technique for manual small incision cataract surgery. though there is increase in minor complication like emesis and SCH with subtenons compared to peribulbar, it is a safe alternative which can be used these days. Thank you.
So what would be your preference
Sir,
if you were to operate somebody close to you,
I prefer subtenons now, sir, after doing this study.
in spite of the fact that you are not getting total akinesia as well as the eye looks red the next day morning?
That's not too much, sir. The only quadrant where we inject that the subtenons anesthesia, only in that quadrant there will be a hemorrhage. That too, not with all the patients. That is
But
acceptable.
nowadays the patients are so sensitive that when we get a small petechial hemorrhage post laser
Surgery.
refractive surgery, they get worried. So this is significant SEH compared to.
Explaining the patient regarding the needle related complications as well, which might happen with peribulbar, this is much better. Convincing the patient is also important with that.
What about the duration of anesthesia? You didn't mention anything about that.
No, ma'am. We couldn't assess the time iconicity was there because
that would be a problem if you want to augment, no? If it is for some reason the surgery takes a longer time.
Yes, ma'am.
And if there is already not complete iconicity and 15% movement is there, then that would add to the problem. So you did not look into that
No,
aspect.
yeah, because we were not hindered with anything.